endocrine pathology, hyperaldosteronism, neuroblastoma, and pheochromocytoma. These don't really fit in with each other, but we're just going to start off with hyperaldosteronism. Relatively easy. It's in the name. You have an increase in aldosterone, okay? Now, increase in secretion of aldosterone from the adrenal gland is going to lead to a main clinical finding of, guess what, hypertension with either a decrease or normal potassium level, right? I mean, that's it. But hypertension is like one of the main things that they like to ask about, right? Now, there's two separate types. Very easy to differentiate. Primary hyperaldosteronism, what do we say about primary? Primary is at the site of the secretion. Well, aldosterone is secreted at the adrenal gland, so that means there's a problem at the adrenal gland. So that means that you're going to have increase in production of aldosterone from the adrenal gland. So you're going to see increased levels of aldosterone and decreased levels of renin because of that negative feedback loop. Very important, okay? So you're going to see bilateral adrenal hyperplasia or an adrenal adenoma that can be usually the cause of it. All right. And so if you try to treat this hypertension, it's going to be resistant because it doesn't matter what you do. It's a problem with the gland. All right. It's just producing too much aldosterone. Secondary hyperaldosteronism. Okay. Well, it's something that's further order. So not at the gland, but the thing that's causing the gland to secrete aldosterone. Well, guess what? It's renin. All right. So we actually see an increase in renin and an increase in aldosterone. That's what's causing the secondary hyperaldosteronism. Okay. So it could be like a JGA cell tumor, right? Renin producing tumor. So many things, right? But that's the key concepts. Primary versus secondary is that primary has decreased renin, secondary has increased renin. They both have increased aldosterone, hence the name hyperaldosteronism. And the main worry for our clinical feature is hypertension. All right. Next is neuroblastoma. For neuroblastoma, this is the most common tumor of the adrenal medulla in children. Okay. So this is a tumor within the adrenal medulla, hence the name neuroblastoma. Because what do we say about the adrenal medulla? They come from neural crest cells. Okay. So they come from those neurocells. So neuroblastoma. All right. What's going to happen is, once again, it's originating from the neural crest cells. And what they love to ask is the abdominal distension. So if a patient comes in, like that's like less than 4 years old, and the mom says, hey, I was like bathing him and I felt like his abdomen was distended and there's like a firm irregular mass that crosses the midline. That's very key because we're going to differentiate that with the Wilms tumor later on. Actually, we already discussed it in renal. But if it crosses the midline, okay, and the mom like finds it while bathing her child, it's like clinical classic vignette. It's firm, irregular, crossing the midline, then you know that you're dealing with neuroblastoma. They're going to ask you, like, where did the cells originate from? Well, it's neural crest cells, okay? Now, what they like to ask is the symptoms. The symptom that's very odd is opsoclonus myoclonus, all right? And all that is dancing eyes and dancing feet, okay? So you have the eyes that are shaking, and you also have feet that you can't, like, keep still. You have clonus in the foot, okay? And we'll talk about that later on in neuro. But it's a very odd presentation. All right. So once again, opsoclonus myoclonus is associated with neuroblastoma, which arises from neural crest cells of the adrenal medulla, most common adrenal medulla tumor within children less than 4 years old. It presents with an abdominal mass. And the last thing that they like to talk about is increased catecholamine breakdown products within the urine. And that's like HVA or VMA. So you're going to see increase in that levels. That's just the catecholamine metabolites in the urine. Why does that make sense? Our catecholamines are made within the adrenal medulla. So if you have a cancer within the adrenal medulla, you're going to have an increase in byproducts that are being broken down, right? Catecholamine metabolites, they're being broken down and sent to the urine, all right? So that all should make sense to you. And they'll say like vanilla. Whenever I saw vanilla, like vanillic acid or something that looks like vanilla, I started thinking about I would always think about something with the adrenal medulla, all right, in catecholamines. And so this is one of them. And so if you see an increase of those catecholamine byproducts in the urine, this is one of the pathologies that's associated with it. There's multiple, but this is one of them, neuroblastoma. But you'll know it by the presentation of like a child and everything else that I discussed. It's NSE positive, not really that important, but for clarity, I just want to add it. And then it's associated with amplification of N-MYC oncogene. All right. Once again, not as high yield. Next is pheochromocytoma. Pheochromocytoma is the most common tumor in the adrenal medulla in adults. All right. So this is in adults. Neuroblastoma was in children. All right. So that's the easiest differentiation that you can give for vignettes. All right. It's derived from the chromaffin cells arising from the neural crest cells. Once again, we already discussed that, right? They like the rule of tens, but honestly, it's relatively lower yield when we're talking about it for a step 1 exam, but it should be probably higher yield when we talk about it in clinical practice. Symptoms. You're going to be someone that has overproduction of catecholamines, someone that has increased levels of like norepinephrine, epinephrine. They're going to be like shaky. They're going to be like worried. They're going to be like looking around. They have like palpitations. They have increased blood pressure. They have headaches. They're sweating all the time. They're pale. They're tachycardic. That's all presentations of pheochromocytoma, and that's exactly how they're going to present in the vignette. Someone that's like really like anxious looking and sounding, they're sweating, increased blood pressure, increased pulse, right? Increased, like they're tachycardic, they have headaches, perspirations, and the symptoms are occurring, very key, very high yield, they occur in spells. So they relapse and they remit. So what does that mean? Patient says like, oh, it happens like every like month or every week. I'll get these random symptoms and then they'll go away and then they come back. All right. And then they go away and then they come back. So understand those symptoms. Very easy to find out in a vignette, to point out, pick out, and then very easy to see that they're relapsing and remitting. Okay. And it makes sense that they're presenting with these symptoms because it's secreting epinephrine, norepinephrine, and dopamine, all of our catecholamines, right? It's causing this. Now, the findings, once again, increasing catecholamines and metanephrines. So you're going to see homovanillic acid, what did I say? Vanilla. Vanilla mandelic acid, vanilla, in the urine and the plasma, right? Because you're dealing with catecholamine breakdown. So if you see vanilla in the urine, think pheochromocytoma in adults, okay, if the patient's an adult. If the patient's a child, and you see vanilla in the urine, then think neuroblastoma, all right? There's also others that we'll touch on later, but those are two of the higher yield things that you have to focus in on. Lastly is chromogranin, synaptophysin, and NSC positive are all for pheochromocytoma, and they want you to know that. So they can say like electron-dense membranes bound with like secretory granules that like stain positive for chromogranin, synaptophysin, and NSC. And the reason they say like electron-dense membranes with like secretory granules is they're just talking about our catecholamines. Catecholamines have really dense on electron microscopy, okay? And they need secretory granules to be released into the blood, right? So that all makes sense. It's just them trying to tell you that there's a lot of those, so that means there's a pheochromocytoma, okay? Lastly is the treatment. They want you to know the treatment, and it's really cool. You have to give the patient irreversible alpha antagonists like phenoxybenzamine, okay? Followed by beta blockers, okay? Now, you have to give the alpha blockage before the beta blockage, because if I block the beta, if I give beta blockers before my alpha antagonists, then all of that catecholamine usage is going to be on the alpha receptors. And that's going to cause hypertensive crisis because I'm going to cause a skyrocket in blood pressure due to the fact that I'm only stimulating the alpha receptors and causing vasoconstriction. Okay? So you have to give irreversible alpha antagonists first, phenoxybenzamine, before you give the beta blocker. But you have to give both. But remember, you have to give the alpha before the beta. Very important. All right? And that is all for our hyperaldosteronism, neuroblastoma, and pheochromocytoma. The next page, we're going to be just talking about the MEN syndrome, multiple endocrine neoplasms, and then the rest of the pathologies associated with endocrine. Hopefully, we'll get on to pharmacology soon. And if you have any questions, please reach out.